Welcome to our continuing series of virtual voices. First, I would like to thank you for your letters and comments, and we would appreciate if you continue sending them to us. I would also appreciate if you could please mute your speakers when the webinar is continuing so that we do not have any extraneous noises. Our speaker today is Dr. Brian Landzberg, who is the gastroenterologist at the Weill Medical College and the York-Presbyterian Hospital, who is on the board of World Information Transfer and has been for many years talking with our interns about his area of specialty, which is travelers' diseases, which all of us need to be aware of. Our moderator is Apurv Gupta, who's on our executive board. Apurv.
Thank you so much, Dr. Durbach and Dr. Brian Landzberg. It's a pleasure to have you with us this morning, afternoon, evening, for a lot of people who are joining our Virtual Voices series from around the globe. As Dr. Durbach mentioned, Dr. Brian Landzberg today will be talking about traveler's diarrhea. He's been part of the World Information Transfer family for many, many years and has on numerous occasions spoken to our interns at the United Nations. So with that, Dr. Brian Landzberg, you have the floor.
Okay, thank you. Thank you for the kind introductions. Everyone can hear me?
Yes.
Okay, good.
Perfect.
All right, so let's see if we can, good. So the topic of today's talk is traveler's diarrhea. And I think it's an important topic, particularly for people involved with World Information Transfer, because you will be traveling to parts of the world in which traveler's diarrhea is quite prevalent. And I think it's important for you to know about because there are many things you can do to prevent and to treat if it occurs. And I think knowledge is power when it comes to this as any medical illness. This is a photograph of my medical center. It's the York-Presbyterian Weill Cornell campus, and its location is important because New York City is certainly a place where we have many return travelers from developing countries. So we do see a lot of return travelers who've recently sustained or continuing to have travel-related diseases. We're also just a few miles uptown from the United Nations. And so I do get the opportunity to treat many patients from the United Nations. And so I do get exposed to a fair amount of travel-related disease for a gastroenterologist. So today's topic is traveler's diarrhea, and you'll hear this condition referred to by many different names, depending on what part of the world the traveler acquires it in. You'll hear it called turista. You'll hear it called Montezuma's Revenge after the Aztec king. Delhi belly when it's acquired in India. So it has a number of monikers that it goes by. We're going to talk about acute traveler's diarrhea today, but I'll also, and we'll break that down as is listed there, epidemiology, presentations, causes, prevention, and treatment. But we should also mention that something I see a fair amount in my practice as a gastroenterologist is this entity of persistent traveler's diarrhea. And this occurs in anywhere from 3 to 17% of people who develop acute traveler's diarrhea. It's a syndrome that goes on for months to even years afterwards and has its own differential diagnosis, meaning its own list of possible causes. But today we're going to focus on acute traveler's diarrhea in those 5 subcategories. So a word about the epidemiology. Acute traveler's diarrhea affects 10 to 40% of travelers to developing countries in Latin America, Caribbean, Southern Asia, and Africa. The incidence of acute traveler's diarrhea decreases with the amount of time that you're away. So it's very prevalent in people who go for a week to Mexico. It's less common in people who travel to Mexico for months, may have property there or other reason to keep them there for months. The incidence of acute traveler's diarrhea drops off. Classic study in Kenya found that it decreased from 36% to travelers who were there for 1 week to 10% in the second week to 3% in the third week of their stay. So it's really, it occurs when you first meet the pathogens of these new environments. And it's the most common illness that travelers tend to complain about. Men and women are equally affected when it comes to epidemiology of acute traveler's diarrhea. But what's interesting is that I tend to see many, many more women than men with this complaint. And that has to do with the fact that, at least in the United States, and at least with regard to gastrointestinal complaints, that women are more likely to access medical care than a man. So whereas a woman is more likely to call up a doctor to complain about the diarrhea, a man is more likely to keep it to himself and not bring it to medical attention. This comes up outside of traveler's diarrhea when you look at a condition like irritable bowel syndrome, where we tend to think that we tend to see 3 times as many women as men complaining of irritable bowel syndrome. But if you stop people on the street and you ask them, do you have abdominal pain associated with change in bowel movements, relieved with the usual criteria for irritable bowel, it turns out men and women are actually pretty closely affected, evenly affected. But women have a lower threshold for coming to a doctor, and that may have to do with the history of seeing gynecologists and other cultural differences. But but men and women are both affected equally by ATD. We tend to see it more in younger than in older. Obviously, the more adventurous travelers, we tend to see it more, and younger people tend to eat more frequently and in more places. We tend to see it more in patients on proton pump inhibitors. And these are medicines that I prescribe all the time, and probably half the people you know are on them. Medicines like Nexium or Prilosec. These suppress gastric acid, which is great for reflux and for healing ulcers. The downside is, though, you lose one of your most important means of sterilizing food. And it turns out that from an evolutionary standpoint, the development of gastric acid is actually a lot more about sterilizing food than about digestion of food. And so when you suppress gastric acid with these medicines like Nexium and Prilosec, we may see upwards of a 10 times risk of acute traveler's diarrhea when patients travel to areas where it's prevalent. And interesting to keep in mind because, as I said, so many people, young and old, are on acid blockers. This is a map that's been updated over the years, but I find it very helpful in terms of what parts of the world are you at highest risk for developing ATD. And so the lighter colors are low incidence, and the dark red is the highest incidence. So you see Mexico is high, no surprise there. Parts of South America, Brazil, Argentina, Chile, Uruguay, less prevalent. Sub-Saharan Africa, high prevalence. The Indian subcontinent, very high prevalence. Within Europe, big difference between Eastern and Western Europe, right? So Western Europe, very, very low incidence. Eastern Europe, as you get into the former Soviet countries, very high incidence of, or at least moderately high incidence of traveler's diarrhea. So if a person says they're going to Europe, you have to ask which country, what settings in that country. And then in Western Europe, you see Portugal has a little higher incidence than the rest, but mainly we worry about it in travelers to Eastern Europe. So what are the risk factors so we talked about being on a proton pump inhibitor and being younger are risk factors in the host, in the traveler. What are the risk factors in the environment that elevate the risk? And the most important risk factor by far that comes out in study after study is the hygiene, restaurant hygiene, food handlers. That is the most, it's as they do various statistical analyses of different countries, different settings, it's the hygiene standards in the restaurants and food service that come out as the number one risk factor. The travel style and budget, street vendors, much higher risk, backpackers, higher risk. 5-star hotels, it's not just about how fancy the hotel you're staying in. It's more about the region and about whether it's buffet style food or served to the table food. Buffet style foods in any setting are much higher risk. There was a classic study done in Jamaica that shows that this is not, we don't just throw up our hands in the air and say, this is what it is when you travel to these areas. If countries invest and intervene with food safety, hygiene, high volume tourist hotels in Jamaica reduce their travelers' incidence by 72% just by improving their standards. So it's with time and some capital investment and teaching, we really can turn this around. Poor access to plumbing, outhouses, more fecal contamination. Electricity is really important because if you don't have reliable electricity, if the electricity is constantly going out, it means food is not being refrigerated in a reliable way and food spoils. And more often than not, the refrigerator comes back on and the food is just stays and isn't thrown out the way it should be. So the electricity infrastructure is really critical. Poor access to water is about food handler hygiene, exposure of fruits and vegetables to contaminated water. Lower risk types of vacations, beach vacations, cruise-based versus land-based generally have lower travelers' diarrhea unless there's a norovirus outbreak in which everyone on the ship gets diarrhea. But overall, cruise-based have lower incidence. Winter travel tends to be lower travelers' diarrhea incidence than summer travel. Higher risk, visiting friends and relatives, adventure tours, all-inclusive hotels, all have higher incidence of travelers' diarrhea. Wet, hot areas, swimming in fresh water is one that people tend to forget. And certainly swimming is something that many people enjoy when they travel. But swimming in fresh water, you really have to think twice about. Swallowing some water is almost inevitable. And depending on the smaller the body, the ponds, the incidence of travelers' diarrhea becomes enormous. And I would, swimming in seawater, sure. Swimming in fresh water, I would tend to stay away from it. Again, just underscoring the point that reducing travelers' diarrhea, more important than anything we do as a traveler is getting countries to invest in sanitation, infrastructure, electricity. Those can reduce diarrhea, travelers' diarrhea more than any personal interventions. GeoSentinel Network, which is a network of doctors that track these types of illnesses, showed that travelers' diarrhea is inversely related to the income level of the country visited. That's no surprise. So the poorer countries will have worse electricity, worse infrastructure, worse water supply. Acute travelers' diarrhea decreases as economies improve and tourism infrastructure improves. And overall, travelers' diarrhea incidence is reduced. Whereas it had been 50 or 60% 20 years ago, it's now more like 10 to 30%. Helping the economies and the infrastructure of developing countries therefore helps American and European travelers too when they go. So I have this this little cartoon of a traveler and a baby because what we notice from a cause standpoint, from a microbiological standpoint, is that the enteric infections that travelers get is often parallel to the infections that we see in young children in those endemic countries, because they're both naive to those pathogens. They're both seeing those E. coli strains for the first time. And so it's often, if you want to know what bugs to worry about as a traveler, you start to look at what bugs, you know, young children get. The presentation of traveler's diarrhea, typically we define it as 3 or more unformed stools in a day, plus at least one of cramping, tenesmus, which is sort of cramping of the rectum, nausea, vomiting, fever, or fecal urgency. When pathogens become invasive, you see blood mixed with the stools and fever, and that's called dysentery, which is a term that you might hear from time to time. It's becoming a bit obsolete, but you still tend to hear it. The average duration, if you don't do anything with acute traveler's diarrhea, it's typically 4 to 5 days long, and you're really only knocked out for about a day, where you really, you know, can't get out of your hotel room. Only about 3% of cases have more than, are severe with 10 or more stools a day. And as I mentioned, 3 to 17% go on to long-term complications like post-infectious irritable bowel syndrome and more persistent diarrhea. There are also these rare extraintestinal manifestations of reactive arthritis or Guillain-Barré, which is a neurological condition that's triggered by the infection. Acute traveler's diarrhea, in terms of how much attention do we need to pay to this if it's really just a nuisance for 5 days? So the good news is it is rarely life-threatening unless you're talking about the elderly, the immunocompromised, or the pregnant. And those are patients in whom you may want to counsel them not to travel to prevalent high incidence areas unless there's a compelling reason for them to go. The other aspect of acute traveler's diarrhea is in the military, and military medicine invests and spends a lot of time on traveler's diarrhea. This was a classic quote from the Civil War. "The death list from disease was a fearful one in the Department of the Gulf. Fever and diarrhea, the former disabling and the latter killing, were worse foes than bullets 10 to 1. Civil War Union Major." So it's a out in the field as a soldier in this time period, diarrhea was killing more men than bullets 10 to 1, which is an impressive stat. More modern era, I expect our imaginations cannot fathom the problems attendant from the absolute urgency for relief from explosive vomiting and diarrhea when experienced within an armored vehicle under fire at ambient temperatures over 40 degrees. So modern era too, diarrhea in the military is a life or death issue. At home in the United States, the usual cause so this is taking a step back, looking at acute diarrhea not in travelers. At home in the United States, the usual cause of acute gastroenteritis is viral. And so we generally discourage antibiotic use because it won't help. The vast, vast majority of domestically acquired GI bugs are viruses. Acute traveler's diarrhea, though, is quite different. And when it's acquired in Latin America or Africa, the vast majority, 80 to 90%, is bacterial. Whereas bacterial are less than 15% of diarrhea acquired at home. So as a general rule, diarrhea acquired at home is almost always viral. Diarrhea acquired as a traveler in an endemic country is almost always bacterial. And so we're going to be thinking a lot more about antibiotics in acute diarrhea in a traveler as opposed to domestic. So if you look at traveler's diarrhea, 80 to 90% are bacterial, especially enterotoxigenic E. coli. Vast majority of Turista, typical acute traveler's diarrhea, is E. coli. Then you have viruses, especially norovirus, which we'll talk about on cruise ships. And parasites, mainly we talk about Giardia, Cyclospora, Crypto, and amoeba. Okay, so as I said, the vast majority, the most prevalent is E. coli. Different forms of E. coli here, 70%. One of the bacteria to keep an eye on that are common are Campylobacter species. Campylobacter species is one that has high issues with antibiotic resistance. And so that will affect our antibiotic choices if you're in an area of the world where there's more Campylobacter, such as South Asia. In Latin America and Africa, Campylobacter is less than 5%, but in South Asia and Southeast Asia, it becomes a substantial player, and that changes our antibiotic recommendations in South Asia and Southeast Asia. Otherwise, we tend to think of traveler's diarrhea pretty similar across the world. So again, acute traveler's diarrhea, usually bacterial. That's a picture of E. coli. It's a gram-negative rod, long cylindrical shape. Another word or two on the microbiology is the idea of infectious dose. So E. coli, different bacteria have different infectious doses, meaning the number of bugs that you have to ingest in order to become sick. E. coli requires 10 to the 6th, 10 to the 8th organisms. Salmonella, similar. Shigella and Campylobacter, though, Shigella only requires 10 bacterial cells in order to get sick. And so Shigella can cause incredible outbreaks from one person, can infect 1,000 easily because it has such a low infectious dose. It also shows that with some precautions, with treating your water, with cooking your food, you're much more likely to be able to prevent these high infectious dose bacteria. Shigella, even if you do your best, you may still get it just because it only takes a few bugs to get through the precautions. This is probably more basic science than you need, but the basic idea of enterotoxigenic E. coli which is the most common cause of traveler's diarrhea, is it involves a toxin that binds to these molecules on the surface of the enterocytes, which then triggers another molecule called adenylate cyclase to make other molecules that then cause water secretion. The point is not so much the details of the signaling, but the idea that E. coli is not an invasive organism. It triggers receptors on the surface of the cells that cause a huge release of salt and water. And so there's a tremendous watery diarrhea, but it doesn't invade. So you don't see blood, you don't see fever. It's just a profuse watery output of diarrhea. Akin to cholera is a more severe example. Other bacterial causes that we come across, which can be non-travel also, most of the E. coli that travelers encounter will cause a watery diarrhea, as I said. There is a subset of E. coli called enterohemorrhagic E. coli that does invade and does cause a destructive bloody diarrhea. And the reason I have the picture of this hamburger chain is because this was the source of a classic outbreak a few decades ago, which sickened many, many, many people very severely, and that was from enterohemorrhagic E. coli, this invasive form. And this was the problem. So rare hamburger meat, rare chopped meat is a problem for a lot of reasons. And the reason, it was the source of that hemorrhagic E. coli outbreak. And it is particularly in domestically or in travelers, it should be avoided at all costs. And there are a few reasons why. Number one, oftentimes the meat that, the bacterial contamination of the meat occurs during the handling of the carcass, of the animal carcass. It can be in the slaughterhouse and the butcher shops, fecal oral contamination of the outside surface of the meat. When you have a steak, the outside surface that was exposed to that fecal oral contamination is charred, right? But when you have ground beef, what was the outside surface of the meat is driven into the center of the hamburger or the meatball or whatever it is. And so it doesn't get, the surface doesn't get charred the way it does when you have a slice of steak or a slice of chicken. The second issue is that when you have a slice of steak, when you have a steak, it's taken from one cow. When you have a hamburger, the ground beef in one hamburger may come from an average of about 200 cattle. So you have 200 times the risk of being exposed to an infected carcass, and you have the outside driven in. So as much as people love rare meat, and if you want to have an occasional rare steak, that's okay, but hamburgers should never, ever be eaten rare for those reasons, as tasty as they are. Okay, this is another case that can be travel or non-travel, another special case bacteria called Listeria monocytogenes. And Listeria is a particular issue for pregnant women. It tends to crop up at picnics, potato salad, food left at room temperature is always going to be a problem. Summer traveler, picnic, food left out at room temperature for hours, uncooled, unrefrigerated, high risk. Other causes of acute traveler's diarrhea. So we talked about causes that E. coli, Listeria, these infect the host, and they may produce toxins, but they're toxins that are produced in the host. There's another series of traveler's diarrhea bugs that cause disease, but not because of infection of the host, but because the host is ingesting toxin that has been formed by the bacteria prior to ingestion. And that term is food poisoning, which is often misused. But the concept of food poisoning is the idea that bacteria have formed the toxin and you ingest the preformed toxin. Classic cases are from seafood. Fish have much higher incidences of these preformed toxin syndromes. Reheated rice from Bacillus cereus. The rice that's been allowed to sit out for a period of time, Bacillus cereus is in the rice, it produces the toxin, and then the rice that's been sitting in the refrigerator for 2 or 3 days and then reheated, you then ingest that toxin. Typically, it comes on very fast and leaves very fast because it's not setting up shop in the host. It's just an ingestion of toxin. Other causes for traveler's diarrhea that are less common, viruses as I said, generally diarrhea at home is viral, diarrhea abroad is bacterial. Small percentage of cases of traveler's diarrhea that are viral. We tend to see norovirus, especially on cruise ships, astrovirus and rotavirus more in kids. Protozoans, which are one-celled bugs, tend to be a more gradual presentation. It tends to present over weeks rather than days. It tends to be in travelers who are there a little longer, not the person who's there in Mexico for a week, but someone who spends 3 or 4 weeks in Mexico. The big ones to think about are Giardia, amoeba. Giardia is a non-invasive, non-bloody. Amoeba is an invasive bloody. Cyclospora, which is seasonal in certain areas, associated with certain fruits, berries, Cryptosporidium. So, you know, until coronavirus came around, usually whenever you'd hear something about a viral outbreak, it tended to be a norovirus outbreak on a ship, and hearing about a whole cruise ship sickened. This was from January 2019, 500 passengers sick on a Royal Caribbean ship. The cruise ships have gotten much more careful about this because it is so devastating and it spreads like wildfire. It came about, its name comes from Norwalk, Ohio, which is where the first outbreak was. It became Norwalk-like virus, the norovirus. It tends to be resolved within 2 days, and generally it's not life-threatening for most people, but again, thousands can be sickened very quickly. And this is why when you go on a cruise ship, you'll see there's constantly people with hand washes and alcohol and other bleach disinfectants. And then I guess we can, as we're going through different pathogens, we can't fail to mention COVID-19, although it may almost be a little welcome break not to hear about COVID-19 for a day. But in this realm of acute diarrhea in general, it turns out that COVID-19 can present with diarrhea in the absence of other respiratory symptoms. So one study that was early in the outbreak, looking at China's Hubei province, they looked at 204 patients who presented to the hospital with COVID-19. And they found that in 99 out of 204 patients, 48%, one or more digestive symptoms were listed as their chief complaint, meaning diarrhea, vomiting, or abdominal pain. Of those 99, 92 eventually developed respiratory symptoms. But there were 7 that actually presented with only digestive symptoms with no respiratory symptoms at all. And the virus is detectable in the stool. So the take home from that is that the gastrointestinal symptoms can predate the respiratory symptoms of COVID-19. And there's a small percentage of people that will only have digestive symptoms with COVID-19. And so we have to have our antennae out for that. And in the same way that someone with a new cough should not be allowed into a meeting, I would say someone with a new diarrhea should also be isolated and tested for COVID-19 if you're in an area of outbreak. It's also affected how we do endoscopy, how we do colonoscopy as gastroenterologists, in that everyone who comes for a procedure has to be tested for it. The virus can be aerosolized when having endoscopic procedures. And so everyone is in masks. In fact, we even have developed this mask for doing upper endoscopies, where it's a rubber mask that fits over the face with a diaphragm, and the scope passes through a diaphragm in the mask to reduce the spray. Certainly the pulmonologists and ICU doctors are seeing the most of this, but as gastroenterologists, we see a fair, and I personally have seen a fair number of patients with COVID-19 related gastrointestinal problems. This is always a fun picture. This is a cause of traveler's diarrhea that when you look under the microscope, it looks back at you. It's more fun when it's a more interactive, we have more of a live group, but this is Giardia. It has the double nuclei with clearing that look like owl's eyes staring back at you through the microscope. And there he is, a little cartoon. Giardia lamblia, as parasites, so most of traveler's diarrhea is bacterial. Then you have a handful of viruses, like especially norovirus. Of the one-celled organisms, the protozoans, Giardia and amoeba are the ones to think about. Giardia especially. And typically, there's an incubation period of about 2 to 4 weeks after ingestion. Similar fecal-oral route of diarrhea. Higher risk daycare centers, international travelers, men who have sex with men. They tend to have malabsorption and upper GI symptoms, diarrhea with steatorrhea, meaning fat in the stool. And that part of that relates to the fact that infectious agents like amoeba tend to hit the colon, the large intestine. Giardia hits the upper small intestine. So you have more where nutrients are absorbed, and so you have more malabsorption. You diagnose it by stool analysis. And the usual therapy is metronidazole for 5 days. There are other regimens that are used in other countries, but in the United States, this tends to be the go-to therapy. This is our friend, or not so friend, amoeba, Entamoeba histolytica. This is a one-celled organism that, by the way, when I move my cursor like this, can you see it?
Yes.
Yeah. Okay, good. So here you see it moves by forming pseudopods, that sort of typical amoeba-like shape. It extends its cytoplasm out and sort of slugs in the direction that it wants to go. These little dark circles, or these red circles, are red blood cells. And one of the common errors, often you'll hear people in New York who are diagnosed with amoeba and they've never left the island of Manhattan. And most of those are non-pathogenic amoeba, which are really common. You know that it's a disease-causing amoeba when you see that it's ingesting red blood cells. So this one on the left is a non-disease-causing amoeba that should just be called basically a commensal or a non-pathogenic stool analysis. This one on the right is a disease-causing amoeba because you can see it has red blood cells in it. And there's a whole bunch of basically charlatans who find these non-disease-causing amoeba and open up parasite clinics, and the vast majority of these diagnoses are complete nonsense. So amoeba has a wide range of disease, from asymptomatic to mild to dysentery to bloody diarrhea and fever. You diagnose it with stool tests or blood tests. And as I said, when they find amoeba on stool, 10 to 1, it's a non-disease causing bug, and it's a false clue. Time of incubation. So those preformed toxin, where you ingest the toxin that's been made already, tends to present within 12 hours and last less than a day. Viruses incubate 1 to 2 days and last 2 to 3 days. Bacteria incubate 1 to 2 days and last 3 to 5 days. Protozoan take 1 or 2 weeks after ingestion. So when someone says they travel to Mexico and on day 2 they develop diarrhea, it's not Giardia, it's not a protozoan. So how do we, now we get to the more practical part. How do we prevent and how do we treat traveler's diarrhea? So food and water precautions, by far the most important. Avoid tap water or well water. Watch out for frozen mixed drinks or ice made with tap or well water. The bugs survive the alcohol. I hear that, well, I had it was a pina colada, so the alcohol will sterilize it. Doesn't do it. Salads are a no-no because they're washed in local water. Fountain drinks are generally made with tap or well water. Unpasteurized milk, raw or undercooked seafood or meat. Most of the preformed toxins are heat labile, meaning if you cook them, they'll be, even the toxins you'll tend to knock out. Moist foods served at room temperature are higher risk than dry foods served hot. Unpeeled raw fruits or vegetables, like berries, buffet style or street vendor. Those are all things to avoid. So some of the do's: carry around alcohol-based hand sanitizers, which everybody's doing these days. Cooked foods served hot, pasteurized dairy products. Peel your fruits. Bananas are okay, strawberries are not. Water, soda, sports drinks that are bottled, carbonated is even safer. Boiled, filtered, or treated water. Ice if it's made with bottled or disinfected water. Hot coffee or tea. Dry foods are very low risk. High sugar content foods are also very low risk. So one of the sort of mantras is boil it, cook it, peel it, or forget it. Boil it, cook it, peel it, or forget it. But there are limitations to this. So it's sometimes the sanitary, how sanitary the eateries are, it's not apparent. You don't know how long food has been sitting out. You don't know that the refrigerator electricity went out last week and they're serving the same food. We don't know if the food was brought to hot enough temperatures to kill before it was brought to the plate. We don't know the employee sinks. And only a minority of travelers really will adhere to all of these recommendations. And the other part of it, of course, is that a key aspect of travel is to sample different foods in their cultural context. So you don't want to travel. I understand that people don't want to travel across the world to eat, to drink bottled water and a jar of peanut butter that they brought. But you have to balance those things with safety. And, a person who doesn't have medical comorbidities might be able to take more risks than someone who does. But it's a risk benefit, that you have to think through when you're choosing to have one of these higher risk activities or foods. Bathing and swimming, we talked about bathing, showering, not to get water in your nose or mouth when you're showering. That's easy to do. Avoid freshwater swimming. I really think that's a higher risk exposure. Elderly and immunocompromised, turns out, should stay even away from water vapor. So spas and public showers, there's a lot of water vapor that actually can carry the bacteria with them. What can we do from a medicine standpoint to prevent? Bismuth subsalicylate, so Pepto-Bismol or other bismuth preparations, prevents 50 to 60%, but it's a lot of pink pills to take every day. It makes your tongue and your stool look dark. It causes nausea, tinnitus, meaning ringing in the ears, drug interactions. So it's not great, but it's one thing that one can do. There are no real vaccines for acute traveler's diarrhea except for cholera. But remember, there are other vaccines. Today we're just talking about traveler's diarrhea. Of course, there are many other health risks that travelers have to consider. And so depending on where they're going, polio vaccines, Hep A vaccines, yellow fever, Japanese encephalitis, there's a whole bunch, and it's worthwhile checking out the CDC website or seeing a travel medicine doctor. Probiotics, this was something that I was interested in. Do probiotics prevent traveler's diarrhea? The net result is inconclusive to negative. They don't hurt, but there really isn't compelling evidence that, that taking probiotics prevents traveler's diarrhea. Antibiotics. So antibiotics for prevention of, not treatment, but prevention of traveler's diarrhea. So you travel to Mexico and you put yourself on Cipro every day while you're there before you get sick. They do work. It's over 90% effective at preventing diarrhea, but there are several big buts. Allergies, photosensitivity. Often people are traveling to sunny places, and many antibiotics, you can't be out in the sunlight because you can get very bad sunburn. Resistance, big one. Antibiotic-associated diarrhea, yeast infections. So there are downsides to it. So whom do we recommend antibiotics for as prevention? Inflammatory bowel disease. I have patients with Crohn's disease or ulcerative colitis where if they go to Mexico and they get traveler's diarrhea, it will flare their inflammatory bowel disease. And so if I can't convince them not to go, then I will put them on preventive antibiotics. The immunocompromised, kidney, stroke, heart patients, or, and this is the harder to define one, cases where there will be devastating consequences of traveler's diarrhea. So if a head of state is traveling to, create peace in the world and it hinges on one meeting, you may put that person on preventive antibiotics. Which ones? Not doxycycline or Bactrim. Yes to ciprofloxacin, rifaximin, or macrolides, medicines like erythromycin.
Dr. Brian Landzberg, since we're talking about prevention, I have a couple of questions that have come in around sort of coronavirus. And I know you touched upon it a little bit, but yeah, I'm conscious of time as well. We have a couple of people asking us that, do you think that the impact of COVID will lessen acute traveler's diarrhea as people become a little more conscious of hygiene, of washing their hands, of what kind of foods they're eating? And particularly, are there any studies that have been commissioned or have been released that are essentially modeling sort of the impact of COVID-19 on acute traveler's disease?
Yeah, those are great questions, and I would assume that there are. Certainly, there's going to be less traveler's diarrhea because there are fewer travelers right now anywhere. But yes, for sure, people are aware of contact, of food precautions in ways that they have never ever had to be before. And so I would be, once travel gets up and running again, I would bet that we're going to see a lot more compliance with food and water precautions, a lot more hand washing. I think people have become much more sensitive every time they reach for a doorknob, that they can't wait to Purell their hands. That was a way of thinking we never really had before. So I would bet that those numbers will go down. I think that the hotels are going to be, as part of their marketing, are going to have to show infection control standards that are much higher than they used to be in order to get travelers to come. So I would bet the numbers are going to all go down. So treatment. We just go through a couple of slides on treatment and then we can entertain more questions. So no other single medical breakthrough of the 20th century has had the power to prevent so many deaths over such a short period of time and at such little cost. The most important medical advance of the century, greatest achievement in medical science, number 2. What has saved more lives than any other and can be built by anyone in their kitchen, back bedroom, shantytown hut, or dwelling? And the answer to this is a cocktail of 8 teaspoons of sugar, half a teaspoon of salt, and 1 liter of water. it's basically, this is oral rehydration therapy. And, you know, before we talk about antibiotics and other things to do for treatment, hydration is the most important thing that you can do. And not just plain water, but this magical combination of sugar, salt, and water is what restores intravascular volume. And the reason is that, let's see if I have this next page. Well, here's another picture of oral rehydration salts. And it's basically the same concept of what's happening in Gatorade or Pedialyte. You know, in Gatorade, you're replacing, you know, the idea was football players sweat, and Pedialyte, you're replacing, you know, electrolyte and water losses from kids with diarrhea. But the concept is that we have a sodium glucose transporter, which means that, so this is the inside of our GI tract. There is a transporter here that only works if you have sugar and sodium present. They will be pulled in together, and then water will follow into the bloodstream, the glucose and sodium. So you will rehydrate someone much better than just giving them sugar water or just giving them salt water by giving them this magical combination. And it really has saved so many lives with readily available materials. Antibiotics. So we said we don't give antibiotics except in rare instances for prevention. We're more likely to give it for treatment because bacteria is the most likely cause. It will keep the symptoms down to 1.5 days and maybe save a trip. And so it had been standard practice to actually give patients going to endemic areas a 3-day course of Cipro or azithromycin if they're going to Southeast Asia where the resistant Campylobacter is, and to tell them to start it if they develop diarrhea. But this article came out in 2016 showing that in travelers who come back after receiving antibiotics for travelers' diarrhea, that there was a huge percent of resistant bugs popping up, and it really concerned everyone. So, you know, the sort of the big thought leader on this, a fellow named Jay Keystone, used to say, don't wait for the bug, give the drug. In other words, we didn't do stool studies. We would just, if you had traveler's diarrhea, just take the Cipro and you'll be well a few days sooner. But now he said, Cantele and her colleagues have convinced me that I may have been wrong, and I hate being wrong. There are good reasons to consider avoiding antibiotic use in the management of mild to moderate traveler's diarrhea, and the main concern is resistance. So our feelings with treatment now or antibiotics, if it's moderate to severe, yes. If it's mild to moderate, maybe not, and maybe stick with Imodium or Lamodal. These are antidiarrheals. Pepto-Bismol can help slow down transit. And then again, just repeating for prevention, boil it, cook it, peel it, or forget it. This is a website, the CDC website for travelers' health is incredibly useful, and I encourage everyone to look it up. Not just, it'll tell you about the political safety in the area. It'll tell you about what diseases are prevalent, epidemics, what vaccines you should have if you're traveling to those areas. And it gets very granular too. You know, you're going to Thailand. Well, are you going to just this tourist area? Are you going to be out in the jungle? And those are incredibly helpful. And everyone should go to the CDC website, Travelers Health, and check that out. And I think we still have a little time for questions.
Well, first, thank you very, very much, Brian. And that was just a wonderful presentation. I always enjoy listening, and I always enjoy very much looking into a little comic that you have on Landzberg. Because, as you know, I had it myself after I went to Ukraine. So that was very, very helpful. I also wanted to mention that two of your brilliant children who have been our former interns are going to be graduating from Harvard University. And that, I think, is just marvelous. And you should be congratulated on helping bring up such healthy, bright children.
Thank you. I'm very grateful to you and to WIT that they had these, as high school students, that they were able to be present at meetings at the United Nations and these wonderful seminars. So it was a very formative experience for both of them that we're very grateful for. So thank you.
Well, thank you. But keep in mind, you have been helping us because every year you have been there to teach the next batch of interns, and we're most appreciative of this. So thank you very, very much. And do we have any other questions, Apurv, that you want to present?
Yes, we have another one from Alex, who writes from Spain, Dr. Brian Landzberg. He's asking if you could talk a little bit about the usage of drugs like Fortasic and loperamide.
The second one is probably loperamide. And the first one, say again?
Fortasic, Fortasec.
Let me just look. It may go, oftentimes drug names have a different, drugs have a different.
They change by country.
Right. So let me just look it up so I know which one. F-O-R-T. Say again, F-O-R-T.
A-S-E-C.
S is in Sam. E-C, Fortasic.
Sierra Echo Charlie.
Okay, just a second. Yes, I see that's a Spanish thing. Let me, you said this is a caller, this was someone watching from Spain, right?
He's also working with us. He's a very, very bright young man.
Okay, yes. No, it's another name for loperamide. Okay, fine. Yes, so loperamide is marketed in the United States under the brand Imodium. And Imodium, right? So yeah, and Italy has a different name, and France has a different name. But Imodium, so when you look at medicines to reduce diarrhea, there's a group that are basically related to the narcotics, to morphine, but not really absorbed into the bloodstream. So they just have narcotics ability to delay gastric transit without the euphoria that you see with narcotics. The weakest in that group is loperamide. Above that, one step stronger is diphenoxylate. And then one step stronger than that is tincture of opium, where it's actually opium tincture. It's just an alcohol solution of opium. The diphenoxylate is also known as Lamodal in the middle. So Imodium, Lamodal, tincture of opium. They're non-absorbed narcotics that put a brake on diarrhea. And I think they're great for travelers' diarrhea, and particularly in those mild to moderate cases where you don't want to reach for antibiotics, they can really put a brake on it. And so you may, as a traveler, carry a couple of loperamide with you. Cases, I would say start with Pepto-Bismol and loperamide. If it's a moderate to severe, you're running 10 times a day to the bathroom, then I would take the antibiotic. The only case in which you would not give loperamide is if it is a bloody diarrhea. The vast majority of cases of travelers' diarrhea are watery, non-invasive. But in that small percent that's invasive and bloody, in those cases, Imodium or loperamide can cause a dilation of the colon that can become serious. So as long as it's not a bloody diarrhea, it's a watery diarrhea, then Imodium is a fine way to, Imodium and Pepto-Bismol are a fine way to start.
Yes, once again, Dr. Brian Landzberg, thank you very much for being part of WIT's Virtual Voices series. We will be uploading this webinar on YouTube so that it can reach a broader audience around the world and part of WIT's network. Thank you everyone for joining Dr. Brian Landzberg's discussion. Hope you can, next time when you're traveling, be more safe and away from acute traveler's diarrhea. Next time, we'll be talking more about WIT's internship program, and a couple of us will be discussing the value we've received from our internships at the United Nations and how we continue to develop the skills that were sown by World Information Transfer. Thank you very much.
Okay, thank you all for listening.
Thank you, Brian. Have a great day.
Thanks, Brian.
And take good care of yourselves.
You too. You too. Everyone stay safe.
Thank you.